Good evening. I'm Dr. Sarah Norbash. I'm the medical director at Messiah Village. Who lives longer? The average lifespan of Americans is around 78. Average lifespan of a physician? Any guesses? Yeah. We're the ones doing all that data entry till 9 o'clock at night in the new medical record systems. Comparing just briefly Canada, basically these are health insurance systems that are socialized, not healthcare provider systems, so they're not really socialized medicine. That's an inaccurate term for Canada because the providers are still private, just as they are for me as a Medicare provider in long-term care. I'm basically paid by the federal government in a socialized system. So it's not socialized medicine. Socialized medicine is a system in which the doctors and hospitals work for and draw salaries from the government in some definitions. For example, doctors in the VA who actually are very happy. They have the best medical record system in the country, in the world maybe. The costs are really minimal. It's hard to get a job in the VA because they're good jobs. A lot of doctors would be happy to work in that kind of a socialized system. Again, touching on the European countries, they have the more, what we consider socialized in terms of doctors actually working for the government. Skip a lot of these. We've got a lot of scare tactics going on because a lot of people have a lot to lose in losing control over privatized health insurance if they're involved in the business of it. And so there's a lot of fear out there that needs to be confronted. In our system, we've got Medicare, Medicaid, the SHIP program, which started, I'd say maybe about 10 years ago. It's relatively new. Before that, there was no coverage for children. We've got the numbers for the Medicare budget. $510 billion is a lot of socialized medicine. The federal government also runs the VA, which I touched on. That's about a $40 billion budget. It covers about 9 million beneficiaries, maybe more now, in many facilities, 70 inpatient facilities and over 1,000 outpatient clinics of various types. Probably 25% more people in the United States than are already covered are eligible for one of those public systems, but for whatever reason haven't been enrolled. So we've saved some money there. But who spends more? Canada spent in 2006 $3,600. We spent $6,700 per capita. This is what government's spending on healthcare already. 15% of the GDP versus Canada's 10%. 70% of healthcare spending was financed by government. In Canada, 46% by the U.S. And we're already more socialized. Through all of the entities that I just described, we spend more per capita than any other nation in the world, but we're the only one that lacks a universal healthcare system. We don't guarantee universal healthcare, but we do have good citizens who have created some on their own, like the Harris County Hospital District, the county, a large number of local government agencies and groups provide free care and reduced cost care. The National Association of Free Clinics claims that member clinics provide $3 billion in services to 3.5 million patients annually. A big debate going on is the idea that we've got to treat people in emergency rooms. If we don't insure them, then the hospitals are absorbing the cost, and that's being passed on to us. And the Emergency Medical Treatment and Active Labor Act is part of that debate. I won't go into the details on the slide, but you know, I've worked in emergency rooms. You can't turn people away. And where do those costs go? And do they get treated? If I referred this CNA's brother to the emergency room to get evaluated, if his vital signs were stable, he'd be sent home. He's not going to get a free evaluation. He's not going to get care. He's not going to get compassion. Not in this system. And that has to change. Life expectancy is slightly higher in Canada. There's a lot of debate about whether the quality of life is better. The drug costs are higher here, as everyone knows, even though Canadians get more prescriptions. That's because when you've got a big group purchasing drugs, you can get them cheaper. And that happened in the Harris County Hospital District. I could get new drugs at substantially less cost for my patients in the district than I could if they were private pay. So a lot of people with Medicare would come and get a gold card to the Harris County Hospital system because they could get their drugs cheaper, even paying for them themselves because we had negotiated lower costs. So they'd go to their private doc to get all their other care and then come to the hospital district to get the prescriptions because it was 10% of what they had to pay on the outside. Things we don't think about that are expenses, the cost of marketing. What's that doing to our healthcare costs? When you got a lot of people in the business of providing healthcare, the marketing costs are tremendous. Every time somebody brings us a free prescription pad and some pens, and you know, that's just marketing to doctors. Look at the television advertising, insurance plan advertising, liability malpractice costs, and then this idea of everyone being able to buy a CT scan, a PET scan, an MRI. That's really increased the costs to all of us because the hospital's got to figure out how to pay for them and starts suggesting higher use of them. How much does the state of Pennsylvania pay legislators through tax money to drum up new legislation? I've only been here 5 years, and I can't tell you how many acts I've had to comply with, how many courses I've had to go to, how many people I've had to train to keep up with Act 52, Act 1, Act 169. I mean, it's like, where does all this stuff come from and who pays these people? We do. I'm going to talk about Denmark only briefly for 1 minute. I like Denmark's system. It's almost completely socialized. They've got a lot of good touchy-feely stuff that really works. They have elder care physician specialists that specialize in nursing home care, that make the choices about long-term care, end-of-life decisions. They don't leave it to families. They talk to families, but families who really don't understand whether a CPR is going to work or not at age 102 don't get to make that decision. That lowers costs when you've got experts that are helping families and helping them make those decisions. Here it's a free-for-all. And that's really increased. That's why we've got 25% of the Medicare budget goes to the last few months of life. And that's not feasible for the long term. So to have experts help make those decisions is not a bad thing. They've got new systems of home health nurses, public health nurses that are all great ideas. Transitions in care issues in Denmark have been looked at for many years. We just started a program in Harrisburg. Ed Wargo and I with Highmark put together a Transitions of Care Forum for the Harrisburg area. Carlisle Hospital, Holy Spirit, Pinnacle, we've all got together. We're in our 3rd or 4th set of meetings to try to reduce costs of readmission, to try to improve safety for patients as they go through levels of care. And a lot of these models in Denmark that I wanted to touch on, and I will skip, really are part of that whole cost issue. It's an enormous cost in the elderly care. Administrative waste was touched on. One study said 31% in this country. I'm not a statistician, but 31% is what I see as being the administrative cost of health spending, compared to Canada's 16.7%. Thank you.